bit. So right here, but this is because I'm not going to do the anatomy review. There's several pages of anatomy review. So as you look through the cardiac section, make sure that you know the anatomy and physiology. I trust that you guys know how the heart works and the vessels and everything, okay? When we start talking about cardiac emergencies, this is really where it starts at. It's the coronary arteries. Remember, the coronary arteries supply the blood to the myocardium, okay? It does it during diastole, so at rest, the blood that's left here in the aorta will enter into the coronary artery system and provide oxygen and nutrients to the myocardium. Where there becomes a problem is where you start having clots, right? You start having plaque buildup and clots in there. Make sure that you are aware of the functions of the blood, the different types of blood cells, right? The plasma, the platelets, the white blood cells, the red blood cells. Make sure that you're aware of the function of those, okay? But where the problem starts is arterial sclerosis, this hardening of the arteries. And you've seen this before. Here's our nice round vessel, okay? You have the different layers of the vessel here. And then as we start eating whole food, okay, like age, 3 or so, we start developing cholesterol and fat on the inside of the arteries. As we continue through life, if we're just real fatty eaters, this is going to be a process. So you trust me, while you're young, watch what you eat, okay? And so that when you get older, still watch what you eat. But what's going to take place here is this fatty streak formation, right? Remember that those cells sort of rupture, okay? And when those cells get into the blood, they start forming a clot there. And as they form this clot, the lumen, see how nice and round this is? The lumen starts to narrow. So, and then a clot forms, and all of a sudden now we have an occlusion, perhaps. But at this point here, where this clot really starts to form up and this plaque starts to form up, is where we get the narrowing. And so, what takes place? There's a couple things that take place with this buildup here. One is the artery becomes hard; it loses elasticity. But what are the other things that take place in that artery? So this is a coronary artery. What's taking place there? That fat is making that coronary artery harder, but what else is taking place? Decreased blood flow because it's narrow. You can get a lot of blood through there. Through there, you're not getting very much blood through that, right? Okay. What else? Very good. Blood pressure. Blood pressure's going because we're putting something inside of this container now, okay? And it's going to raise the pressure in that vessel. So we learned last year of how to interpret EKGs, correct? The heart has its own electrical system. The EKG offers only electrical activity of the heart, right? So it shows you from the SA note down to the Purkinje fibers the electrical activity of the heart. Remember the EKG complex, the P wave represents atrial contraction, the QRS complex represents ventricular contraction, and then the T wave represents ventricular repolarization. You don't really have to know the EKG stuff as far as the EMT, but keep in mind that the heart has its own rich blood supply, okay? Its own its own artery system and the coronary arteries, and it also has its own electrical system as well. So when we get to that point, like I said, it decreases oxygen flow to the myocardial myocardium itself, right? So hypoxia takes place. Get the little ischemia in the tissue. Remember, ischemia is lack of oxygen to the tissue. So we get a little ischemic, and then you see the changes in the EKG. PVCs are the sort of the wide complex. Remember PVCs? Wide QRS complex, premature ventricular contractions. So as hypoxia increases, we'll start having PVCs, may lead into VTAC or a lethal rhythm in the ventricular fibrillation as well. Then we have the blood pressure. Everybody savvy's blood pressure, right? Pressure exerted on the arterial walls. So that plaque buildup and everything will increase blood pressure because it's going to give a more resistance to the blood flow. It's going to increase the pressure. And then we won't get adequate circulation. Move your mind back, so I don't give you a seizure going back to the picture, but move your mind back to that picture with the Vico clot in there. I mean, there's just a little room for the blood flow to get through that clot, right? That's one reason that we give aspirin, okay? And then that's another reason that we'll give nitro to try to dilate that vessel out a little bit to allow more blood flow. Give the aspirin to thin the blood down. So there's an do you remember STEMI? ST elevation MI, okay? The cardiac monitors outside of your standard of care, but you have someone having a possible heart attack, so you're transporting them to the hospital. Time is of the essence because they could be having a heart attack. The old saying is time is muscle, right? So they need them to the hospital as quick as possible to rule out that they're not having an MI, they're not having STEMI. Okay, they have a window of opportunity that they need to get this patient into the cath lab. So time is very critical when someone's having a possible heart attack. If they're having cardiac-related symptoms like chest pain, shortness of breath, pressure type pain, nausea, vomiting, right? Pain that may radiate into the arms, the back, the neck. Those are all cardiac-related problems. So this patient is having a heart attack until proven otherwise. You can't prove that pre-hospital, so they have to go to the hospital. So you treat the patient as they are having a heart attack until proven otherwise. Right? We treat worst to least. So we want to treat this patient like they're having a heart attack. There's a lot of different names for cardiac events. Coronary artery disease. I think there's one coming up here. Arterial sclerosis. There's one acute coronary syndrome, ACS, acute coronary syndrome. So in these they fit in where they put into the two anginas, right? The unstable and stable angina, and then you have the myocardial infarction there. So the myocardial ischemia, just like we talked about, this narrow arteries, this narrow coronary artery is not allowing the proper blood flow to the myocardium, so it's not getting adequate oxygen and nutrients, okay? So you get a little ischemic tissue. This is different than hypoxia. Hypoxia is what?
Decreased oxygen to the cells.
Cells. Right? This is decreased oxygen to the tissue. So ischemic heart is decreased oxygen to the heart, right? Cerebral ischemia, decreased oxygen to the brain, right? Okay. So let's talk about the two angina pectorises. This should be familiar to you. All right? So you have, let's just set up a scenario here, and let's talk about Steve. Steve's your patient. He's a 65-year-old male patient, and he's had a cardiac event in his life before. Okay, he's been to the cardiologist. May or may not have had a heart attack. Let's say, Yeah, he had a mild MI, a small vessel MI, right? So his cardiologist is telling him, say, hey, you're going to have chest pain, okay, with exertion. So when you exert yourself, expect that you're going to have chest pain, right? It's stable angina, or what we call predictable, because it is very predictable, okay? So the cardiologist is telling Steve, said, hey, when you get out and cut your lawn, when you walk that 18 holes of golf, you're going to have you may develop some chest pain, okay? You'll feel the pressure in your chest. You may feel short of breath, right? So when you feel that, I want you to stop, rest on that tee box, go find your bench, rest before you walk to number 9, right? Take a breath. If you're still having this chest pain, go ahead and take a nitro. I want you carrying those nitro with you wherever you go, okay? This is this guy that's had the cardiac event, that's leading a fairly decent lifestyle, okay? But he's just now having chest pain. He's having stable angina. So he does what the doctor says. He's coming off of a great birdie on number 8. He's starting to feel this little pressure in his chest. So he goes over there, number 9, and he sits down and he starts to rest. And the pain's going away a little bit, okay? Not quite. He's still feeling some pressure. So he digs in his golf bag and he finds his nitro and he takes a nitro tablet. All right. He sits there a little bit longer, 5 minutes or so, and the chest pain goes away. And he goes, wow, that's exactly what the doctor told me would happen. That's stable, correct? Stable angina. So it's very predictable. So when he Steve overexerts himself, this is what's going to take place. All right? Now, let's change the scenario a little bit. Let's say now that Steve is asleep in his bed, okay? Or Steve is watching that could give him a little chest pain, watching the last golf tournament of the year. That could hurt a little bit. But he's watching some TV, some golf, he's relaxed, okay? Or he's just dead asleep. And now he wakes up with the chest pain, the pressure, right? The short of breath, okay? Or he's just sitting there, he's having his soda, eating some chips, and watching golf, and goes, wow, my chest is hurting, okay? And so he goes, well, wait, that doctor told me to take a nitro. So he takes a nitro, and it really doesn't go away. It may go away, it may not, right? But do you see the difference? Okay, now he's at rest. He's not exerting himself. He's at rest, and he's having the cardiac-related chest pain, the pressure. All right? So he's having this pressure pain. That becomes unstable, especially the pain that wakes you up at night or wakes Steve up at night. It's unstable. My recommendation for unstable angina, or USA, okay? Yeah, go figure. Unstable angina is Steve needs to call 911. He needs you to come out to his house, transport him to the hospital, because I can't tell you how many times that I've been doing chest compressions on Steve, right? And the family's telling me, some of them said, we're going to the cardiologist. We were going today to the cardiologist. He was having some chest pain. Or we have a appointment with the cardiologist tomorrow, right? Don't think so. But so the unstable angina is a medical emergency. That needs to be taken care of, especially if the chest pain doesn't go away. Right? So he wakes up at night, he takes a couple nitros, he can't get the chest pain to go away. That guy needs to go to the hospital by ambulance, not by private car, by ambulance. Okay. Any unstable angina, I think, is a medical emergency. So that person needs to go to the go to the hospital. The stable angina, not so. It's predictable, right? Don't. This cardiologist saying, don't call 911. You're out there walking the golf course. Take rest. Take the nitro. See if it'll go away, or you'll be broke with ambulance bills. You know, before with stable angina. These cardiac patients are educated on this. They're very well educated on the difference. The only problem that comes in is sometimes they're very stubborn. So they're having that unstable angina and they just won't call it. They won't go. They say, oh, it's just angina. I'm gonna take my pill, you know. But anyhow, rest and nitroglycerin for angina pectoris. But you notice that even with unstable angina, the pain goes away, right? Pain goes away. The patient having the MI, typically, we always say typically with this chest pain stuff, the pain doesn't go away. The pain is constant. So the person having the MI has constant chest pain, pressure type pain. You know, it feels like you're sitting on me. It feels like they're squeezing me. Okay? Pain, when you ask the patient for chest pain, are you having any pain? Chest pain? Pressure and heaviness is the same as pain. Okay, rate that on a scale of 1 to 10. We'll rate that heaviness on a scale of 1 to 10. It's the same. Some people will say, well, I'm not having any pain, but this pressure is like to kill me. See, it's the same event. Okay, same thing. Treat it as the pain. Anyhow, these vessels constrict. They lack of oxygen. They're going to spasm and they're going to constrict, which leads to the angina. Okay, so you give them the nitroglycerin. They open up. Oxygen is restored to the ischemic tissue, and then the pain goes away. The pain is caused by the lack of oxygen. Right? It doesn't take very long when you go from no oxygen, right, to an anaerobic metabolism, because oxygen is aerobic metabolism, so we go to an anaerobic metabolism, and when we do that, when this patient does this, they build up a lactic acid, and then they start having pain from it. That's the same pain that you and I feel when we run up and down stairs in our legs, right? We can't get enough oxygen to the muscles in our legs, and they start to hurt, correct? Because we're building up lactic acid in them. The same way, we've switched to an anaerobic metabolism. We build up lactic acid in our muscles. The heart is very similar in the way that it builds up the lactic acid. All right. So we're good with unstable angina, stable angina. We're good with those two. Okay. The treatment's the same. If you had a patient with angina, then you would administer a nitroglycerin. You know, eventually. Okay, eventually. There's a few more things that you have to do. Women, diabetics, they usually don't have the classic presentations. Sometimes the only complaint is nausea. I'm nauseated. Okay? As my paramedic instructor said many moons ago, any pain above the belly button is cardiac related until proven otherwise. Saved my bacon a lot of times, by the way. Okay? So any pain above the belly button is cardiac related until proven otherwise. They just don't. Sometimes women have what's called silent MIs. I've seen it. I've seen diabetics have a silent MI. Okay? And just hardly any signs and symptoms. That's why on the ALS side, all diabetic patients get a 12 lead. We do a 12 lead on all of them to make sure that they're not having an MI. Usually if the woman has any sort of problem, again, above the belly button, any pain, we do a 12 lead to rule out that end of the STEMI, to rule out the STEMI, okay? So women in diabetics pose a special problem. So just weakness, lightheadedness, because they get in there and they say, no, I'm just lightheaded, I don't feel good, you know? Still, think about cardiac, think worst to least, right? Let's say you have this guy, let's say you have Steve, and all of a sudden Steve he's active, you know, somewhat. He walks occasionally instead of rides the car, and so he's fairly active, but his complaint is, man, I'm feeling weak. I just can't get my breath anymore. You know, I used to be able to walk these hills, and now I just can't get my breath, catch my breath, right? Think cardiac. Think something, you gotta get that pump checked out, okay? Because weakness in men is a big deal. It's this unexplained weakness, okay? All right, so angina pectoris, always do the good assessment. Do your assessment flow chart, right? Supplement oxygen if needed. So if they are in some type of respiratory distress, they're using accessory muscles, okay? They're complaining of dyspnea, right? They're complaining of difficulty breathing. If their SpO2 is below 94%, then administer oxygen. If they're not exhibiting any outward respiratory distress signs and symptoms, and their SpO2 is above 95%, right? No oxygen. They've proven a long time ago that oxygen is bad. Excessive oxygen is bad. Unneeded oxygen is bad. When someone's having a heart attack, it worsens the heart attack. This is coming from the American Heart Association, okay? So it worsens the MI. So evaluate the need for oxygen. It deals with these free radicals, okay? When we get really bored, we can talk about the free radicals that excessive oxygen produces. But it does cause damage to not only the MI patient, but the stroke patient and the trauma patient. You have to evaluate the need for oxygen, okay? Administered nitroglycerin, and here's the magic number. You know, some books say 100, some books say 90. So I believe our book says 90. So that would be what it would be on an exam. And this is what I would go with the registry, 90. Okay? Hopefully they won't put up 190 on there, right? But because the range is actually about from 80 to 100. I think the package itself says 80, but we'll go with 90. So 90 is the magic number. Okay. Administer aspirin if protocols allow. So go ahead and administer the aspirin. In test land, we have standing orders. Okay. So whatever medications that we teach here in class, they're standing orders. So oxygenate them if needed. Give them the aspirin, the 4-baby aspirin or 1 large regular dose aspirin if they have water. Okay, and then nitroglycerin. So we have to evaluate the blood pressure, right, before we give nitro. Okay, we have to do that. Medication, are you on any medication? Remember the erectile dysfunction drugs. That's a big one. And then look at always take the blood pressure before you administer the nitro. And then if it's angina pectoris, then it's going away. This pain is going to subside. If it's an MI, then it probably won't subside completely. Okay. So everybody still good with the 2 anginas, right? Okay. Let's talk about this MI for a few minutes. Okay. So about 30 minutes or so is what most people says. So about 30 minutes, that tissue is going to infarct, or that tissue is going to die without adequate perfusion. Okay, so you oxygenate the patient, trying to get them get perfusion down to the area, because let me see if there's a picture. Nope. Okay. So with the let me draw. So with the MI, and you've seen the pictures before, right? So with the MI, that's a big heart. They must like a lot of people. So you have a coronary artery coming down, right? And it's branching off all the way down. And let's say our clot is going to be right here at this bifurcation. Right? So everything distal from this clot is not going to get oxygen. Okay? If it's fully occluded, nothing's going to get by there. Okay? If it's fully occluded, then this patient's probably going to go into sudden cardiac arrest. Okay? But what we want to do is we want to do our best to try to get blood flow distal to the clot. Okay? So we're going to give them the nitro to try to dilate it. We're going to give them the aspirin to try to thin that blood to get through that clot. Okay? Because we know in about 30 minutes or so, that tissue is going to die. Once the tissue is dead, it's dead. Okay? The patient's going to lose a lot of function of there. I have to say the word so because they're going to have a wall abnormality. Wall abnormality. Because what happens is, got to use my little hands here. This is the way the ventricle normally pumps, right? You know, like this. So if there's this big infarct over on this side, it's not going to pump. You're going to lose contractility, correct? So now you don't have this, right? This is not pumping. This is infarcted. It's dead tissue. It's not going to contract. So you're going to get this, all right? Wall abnormality, okay? So we have to try to get blood flow down through there. If they're really having a big clot in here, this is the time. Time is tissue, right? So this area distal to that clot is going to die off. So we need to expedite this patient to the hospital, a heart hospital, one with a cath lab. Cardiac cath, they'll go in there. You'll take them in, say, no, you know, they're doing a quick 12 lead, yeah, they're having a STEMI or whatever, and then boom, straight to the cath lab. Have y'all seen that before? During your time in the hospital, someone come in with a STEMI?
Oh, yeah.
Yeah.
They did compressions on them, then they transferred to the cath lab.
Yeah. Yeah, I mean, as soon as they come in, if they're still alive, you know, I mean, it's within minutes that they're going to the cath lab. It's just like the guy today came in with the patient today with the stroke. They thought she was having a stroke. She went from the ambulance straight to the straight to the CT. So their goal is to really get that patient from the back of the ambulance that's having this infarction to the cath lab as quick as possible. So, one, the ischemia, this arrhythmia, it affects the ischemia affects the electrical properties of the heart as well. Okay, so electrically they're going to start having this arrhythmias. Wide QRS complexes, irregular heartbeat. Okay, runs a VTAC right before they go into ventricular fibrillation. Then you get to use that AED, right? So, treatment, definitive treatment, we want to restore oxygen we want to reperfuse the myocardium, get this clot out of there, and the only way to do that is in the cath lab. Okay, that's the goal. We want to get this patient to the cath lab. Okay, time dependent. Again, look at the diabetics, the elderly women. Maybe the only thing they're complaining of shortness of breath. right? Nausea, some weakness, right? Now I say any pain above the belly button, right? Nausea would fit that, right? Yeah, nausea is in there. So anything above the belly button. Think about, could this be cardiac? So let's look at this for a second. Get back up so you can see it. The signs and symptoms. I'm sure you have this picture in your book. Substernal chest pain, pressure type pain, radiates in the neck, in the back, the jaws, right? Heaviness, and discomfort, and squeezing. It's usually 2 to 15 minutes activity. Okay, so this guy may just be having angina, but it may not stop, right? With exertion, stress, meals. We joke every year about who's going to do the first CPR on Thanksgiving. We actually bet on it. There's always someone that seems like goes into cardiac arrest right after Thanksgiving meal. They eat so much. How can you turn down all that pie? Anyway, so they could be. Now this is angina pectoris. Oh, I see the label now. So this over here is angina. See, it usually goes away, right? So the substernal chest pain in an MI is the same. The radiation's the same. The discomfort, it's probably more intense. So over here with angina pectoris, it may be, a 4 or a 5. Over here, it's probably a 10, correct? 9 or 10. It lasts longer. It probably won't go away. And with my experience, the chest pain, I never could get someone having a heart attack. I never could get the pain to go away. They always had chest pain. Right? With the MI, all of a sudden their skin starts to change. They sort of get ashen. They get a little gray. They start getting dizzy. Okay. And like it says here at the bottom, the nitroglycerin may not give complete relief. Right? So they'll get some relief, but they won't get complete relief from it. So make sure you have your AED available. Manage the airway always. Right? Do that good assessment. Your sample, your OPQRST. Follow that flow chart. Evaluate oxygen. Give the nitro. Give the aspirin. Definitely notify the receiving facility. See, it says early. Early. Give them plenty of notice. Get on that radio and notify the receiving facility that you're coming in with someone with a possible MI. Because who are they going to get ready?
Cardiologist.
And cath lab. Yeah. They're going to get the cath lab ready. They're going to call the doctor, the cardiologist down. They're going to get the cath lab crew ready. More than likely, they're going, let's say you give them 10 minutes, more than likely the cardiologist and their cath team is going to be waiting for you. Being BLS, you can't do the 12 lead, right? So they'll whisk that patient in the room. They'll do a quick 12 lead and say, yep, having a heart attack, and then boom, down the hall they go. I've seen them start IVs going down the hall. You're doing everything en route, going down the hallway. Okay? They waste very little time getting the patient to the cath lab. And then ALS early is available. Why do you want to? It doesn't say early, but request ALS. Why would you want to request ALS? Yeah.
They can do the 12 lead.
Very good. They can do the 12 lead. Okay. They can confirm the STEMI. Okay. And they can give they can get the IVs going, and they also can give some more drugs. Give some morphine and stuff to reduce that preload, so they can give more drugs. Okay. There's a flow chart in your book to look at. Okay. When you sort of go through it, your treatment, but it's pretty straightforward, right? Do a good assessment. Consider cardiac almost all the time. Look at your medications. Get a good history. And then remember, your end goal is to get this. If this is your patient here, your end goal is to get this reperfused. Okay? BLS wise, EMT wise, you just can't really do that, but you can help. Great deal. Okay? So maybe that you give that nitro and you just get enough dilation to get a few red blood cells passed to keep this patient from going into cardiac arrest, right? You get enough oxygen to that tissue to keep them from dying, and then they get to the cath lab, right? It's real. Okay. Anything else? We'll stop here. We won't go into aneurysms. Yeah.